Welcome to the module focused on diabetes pharmacology as part of the comprehensive exploration of diabetes elective at UNC School of Medicine. In this module, we will discuss the ominous octet, why it is important to treat diabetes intensively, and also discuss both insulin and non-insulin medications. We will be covering all of these things and their characteristics, and we will not be covering any information on medication initiation or regimens because these will be discussed in another lecture. The paper I have cited at the bottom describes what is called the ominous octet. These are 8 mechanisms that result in the pathophysiology of type 2 diabetes. They are important mechanisms to understand because they are the mechanisms upon which our current medications work. You can see the mechanisms and medications in this photo from one of Dr. Young's lectures from the foundation phase. The mechanisms are as follows: reduced insulin secretion from pancreatic beta cells, elevated glucagon secretion from pancreatic alpha cells, increased production of glucose in the liver, neurotransmitter dysfunction and insulin resistance in the brain, enhanced lipolysis, increased renal glucose reabsorption, reduced incretin effect in the small intestine, and impaired or diminished glucose uptake in peripheral tissues such as skeletal muscle, liver, and adipose tissue. This slide is adapted from Dr. Young's PowerPoint from foundation phase. So the question is, why do we treat diabetes intensively? In short, earlier treatment with pharmacotherapy will decrease the damage to organs, vessels, and nerves that cause life-changing complications, often called microvascular complications. There are 2 trials that prove this, titled DCCT and UK-PDS. This slide is also from Dr. Young's lecture discussing the main results from the DCCT trial, which was focused on type 1 diabetes. Intensive insulin treatment reduced microvascular complications, including reduced incidence of retinopathy, which was evidenced by reduced cumulative incidence of 3-step worsening of retinal photos, decreased nephropathy or kidney disease as evidenced by reduced cumulative incidence of microalbuminuria and albuminuria, and also reduced prevalence of neurological abnormalities on neuroexam and nerve conduction studies. This slide is also from Dr. Young's PowerPoint. As you can see, the conventional group compared to the intensive group shows both lower A1C and average glucoses in the intensive groups compared to the conventional group. This slide is also from Dr. Young's PowerPoint. The UK-PDS trial focused on type 2 diabetes. As you can see, the results showed that the intensive treatment group resulted in lower A1C and lower microvascular complications as compared to the conventional group. So now we will talk about insulin. Insulin was discovered in 1921 and has saved many lives. There are multiple types of insulin, and they serve different roles in the treatment of diabetes. The different types include rapid-acting, short-acting, intermediate-acting, and long-acting insulins. The chart pictured here shows the timeline of action for different insulins. As you can see, the rapid-acting peaks very quickly, while the longer-acting one lingers around in the body much longer. This is very important in how they are used. Insulin acts on the insulin receptors in our bodies in an effort to either supplement in type 2 or replace in type 1 the insulin that we physiologically produce. Insulin is normally injected, but can also be inhaled in some cases. There is no limit on A1C change in theory because insulin can very effectively lower someone's A1C. There is a high risk of hypoglycemia and a risk of weight gain. Side effects include atrophy of the skin at the injection sites from the multiple injections that insulin requires. Some special notes about insulin include the risk of DKA. If a patient who uses insulin has an injury, illness, or surgery, this means that their body is under more physiologic stress. This means that they should be closely monitored to ensure that blood glucoses are kept in an appropriate range and that they have adequate insulin coverage to prevent DKA. So before we talk about each type of insulin, I wanted to talk about basal and bolus insulin. Our body has a basal and bolus system by which insulin is secreted. We constantly release insulin to maintain euglycemia, which is our basal or baseline insulin. We also have spikes in insulin, which are released after glucose or food is ingested, and this is our bolus insulin. This is evidenced in this photo on this slide, which shows a spike in glucose followed by a spike in insulin, either naturally secreted or injected. We can use the different types of insulin and their characteristics to our advantage because they each have different time ranges of action, which can simulate our natural response. For instance, whenever we are looking to provide a basal or baseline insulin to mimic our natural basal release of insulin, we can use a long-acting or intermediate-acting insulin, which will release slowly over time to help us maintain euglycemia. We can also use rapid and short-acting, which are useful for bolus or mealtime insulin, so that we can use this quicker-acting characteristic of these drugs to address the spikes in glucose. First, we have the rapid and ultra-fast-acting insulins. The rapid insulins are Humalog or Lispro, Novolog or Aspart, and Glulisine or Apidra. There's also a newer ultra-fast-acting insulin called Fiasp or NovaRapid, and it's a fast-acting Aspart. When insulin is injected, it is similar to human insulin. Longer-acting insulins will form hexamers and be absorbed more slowly because they do not resemble human insulin as much. Since rapid-acting insulins resemble insulin more closely, they form monomers very quickly, which allows them to enter the bloodstream quickly and act quickly. For this reason, you can take these insulins 10 to 20 minutes prior to a meal, which makes it easier to adhere to. The quick peak of this insulin allows for prevention of high postprandial or after you eat glucose spikes, which can contribute to worsening A1C. You can see this on the chart indicated by the yellow star. The quick action of this drug allows it to be used as a bolus prior to meals. Short-acting or regular insulins, Humulin R and Novolin R, are injected into the subcutaneous tissue and are not as similar to natural insulin as the rapid-acting insulins. This results in the formation of hexamers and slow conversion to monomers and dimers. This results in a delayed absorption into the bloodstream and therefore a delayed peak in effect. Since this insulin has a delay in action, people have to take it 30 minutes prior to a meal, making it less convenient and harder to adhere to. However, if taken correctly, it is still effective at lowering postprandial glucose spikes, so it can also be used as a bolus insulin. Intermediate-acting insulin is called NPH or neutral protamine hagedorn. The addition of protamine allows for the insulin to be released more slowly and for the effect to be drawn out and last longer. It's marked by the yellow star and shows a peak of 6 to 14 hours and a duration of 10 to 16 hours. This allows for it to be used as a basal insulin, but might need to be dosed twice daily. It's a useful tool in the hospital when you're titrating insulin since it only lasts half the day. This means that you can titrate and adjust it more often since it does not hang around for more than half the day. This compares to a longer acting insulin where if you give it, you have to wait an entire day to adjust it, which may cause hypoglycemia or may take longer for you to reach your target insulin or your target glucose. Long-acting insulin goes by the names Glargine, also called Lantus, Detamir, also called Levemir, and Degludec, also called Tresiba. This insulin is useful in providing a basal level of insulin, which will act as a counter-regulatory mechanism to glucagon in order to maintain euglycemia. In type 1 diabetes, basal insulin is required to keep DKA from occurring, and these medications are fantastic for this. As you can see in the photo, the long-acting insulin has a long-lasting effect and is stable, which mimics our natural basal insulin release. Premixed insulins, which go by the names Humalog 75-25 or 50-50, meaning 75 or 50% Lispro-protamine and 25 or 50% Lispro, and Novolog 70-30, meaning 70% Aspart-protamine and 30% Aspart. These are mixtures of short and intermediate acting insulins. The addition of protamine allows for slower release of the insulin and turns it into an intermediate acting insulin. It is typically taken 2 times daily before meals so that it provides a bolus dose for the meal as well as a basal insulin. The pros are that it makes it easier on patients by minimizing injections and prevents them from having to mix their insulins and pay attention to which insulins they are injecting. The con is that the medication is in the same proportion every time, which can cause hypoglycemia if the carb amount differs between meals. It is also harder to titrate because the proportions do not change. Inhaled insulin is an option as well, but it is not called on for various reasons. However, it does seem to be a promising alternative for some people to subcutaneous insulin injections. Afrezza, or Insulin Human, was approved in 2014 and is a rapid-acting insulin inhaled prior to meals. It requires PFTs or pulmonary function tests and good results on these tests prior to initiating. It is contraindicated in asthma and COPD and in children at this point in time. So it's a very niche group that can take these medications, which is one of the reasons that this treatment has not caught on yet. Now we will talk about non-insulin medications. This is a chart showing the treatment algorithm for non-insulin medications. We will go over treatment regimens in another module, but I just wanted to provide you with this chart to help get you oriented to the stepwise approach that can be used to treat patients with type 2 diabetes with non-insulin medications. For instance, it is helpful to know before we go over these medications that certain medications are good to help with weight loss, CKD, CHF, or ASCVD, which is important to know when you're treating patients with multiple conditions or multiple goals. We will go over this in more detail later, but I wanted to provide it here before we go over these medications. Now we will go over the biguanides. The names are metformin, which come in Fortamet, glucophage, and Glumetza. The mechanism is that it reduces insulin resistance in peripheral tissues, increases liver utilization of glucose, and stops gluconeogenesis through inhibition of hepatocyte mitochondrial enzymes. I'm providing the dosing of these medications not in an attempt to provide you with the extensive dosing regimens that can take place for patients, but to just give you an idea of the ranges and the numbers that are used for different medications so that whenever you're in the clinic, you can tell if this patient is on a high dose, a low dose, and kind of get an idea of kind of where they're at. So the dosing for metformin depends on whether you are using an extended versus immediate release tablet. The immediate release tablet will normally be 500 milligrams BID with an increase in 500 weekly to achieve a maintenance dose of 2,000 milligrams daily, or 1,000 BID. If you're using the extended dose, you will do 500 to 1,000 milligrams oral daily with an increase in 500 weekly to achieve a maintenance dose of 2,000 milligrams daily. Typically, if you are using 2,000 milligrams, you will take 4 500 milligram tablets in the morning since it's an extended release as opposed to BID in the immediate release. To avoid side effects, you can always start at a low dose and increase slowly, since there are a few side effects that come with metformin, as I will talk about in 1 second. The administration is orally. A1C change is, on average, is 1 to 2%. There is no risk of hypoglycemia. In terms of weight, there may be a mild loss secondary to possible GLP-1 action, which causes the patient to feel fuller and have more satiety and eat less. The side effects include lactic acidosis in the setting of CKD, nausea, vomiting, diarrhea, B12, and folate deficiencies. Some special notes are that metformin is renally excreted, which means you need to dose reduce in CKD, and if the GFR is less than 30, discontinue it. You need to check renal function prior to initiation whenever you do a dose change, and also keep an eye on the renal function while you're giving this medication. If the patient becomes sick and has nausea, vomiting, or diarrhea, stop metformin to avoid DKA. When type 2 diabetes patients progress to beta cell death and begin to take on more of a type 1 diabetes presentation, such as catabolism or weight loss, then metformin will not be as effective because metformin performs better when insulin is present. Now we will talk about incretin mimetics. The incretin effect, which is when hormones such as GLP-1 and GIP are released in response to glucose that has been eaten. The incretin effect causes 50 to 70% of insulin secretion. GLP-1 is degraded by DPP-4 in a matter of minutes. It is thought that the incretin effect is not fully functioning in type 2 diabetes, so insulin does not get released when glucose is ingested. Medications in this section include GLP-1 agonist, GLP-1 and GIP agonist, and DPP-4 inhibitors. GLP-1 agonists include dulaglutide or Trulicity, which is a weekly medication, exenatide ER or Bydureon, which is a weekly medication, exenatide, which is also Byetta, which is BID, semaglutide, which is Ozempic weekly, liraglutide, which is Victoza daily, semaglutide, which is Rybelsus oral daily. The mechanism is that these drugs act on the GLP-1 incretin receptor, which causes insulin to be released. This also slows emptying of gastric contents, which makes patients feel fuller longer. It also decreases the secretion of glucagon. Two examples of dosing are liraglutide, which is 0.6 milligrams daily for 1 week, and then you can increase that to 1.2 daily with a max of 1.8 daily. Semaglutide, subcutaneous, is 0.25 milligrams weekly for 4 weeks, then you can increase 0.5 weekly with 0.5 milligram increases to get the glycemic control that you're aiming for. The administration is either orally with the semaglutide Rybelsus or an injection, and the time frame by which you would give these medications vary between the drugs from BID to daily to weekly. The A1C change on average is 0.5 to 1.5%. There is not a hypoglycemic risk unless you mix these drugs with sulfonylureas. They are also glucose dependent, so require an elevated glucose to have an effect, which makes this drug unique, and on its own does not cause hypoglycemia. For weight, we will see weight loss because this medication slows the gastric emptying and makes patients feel fuller longer. Side effects include pancreatitis, nausea, vomiting, C-cell thyroid tumor, so it's contraindicated in MEN type 2 and medullary thyroid cancer. Some special notes about GLP-1 agonists are that they're useful in patients who desire weight loss or need weight loss to help with metabolic syndrome. There's also a benefit shown in CKD. Interestingly, since GLP-1 is naturally degraded by DPP-4, these drugs are engineered to avoid DPP-4 degradation. A newer class is GIP GLP-1 agonists. The name of the drug is tirzepatide or Mounjaro. The mechanism is that it is an agonist at GIP and GLP-1 instead of just GLP-1, which are both incretins, resulting in increased insulin release and slowed gastric emptying and satiety. The dosing for Mounjaro is 2.5 to 15 milligrams subcutaneous, and it is a weekly medication. It is given by an injection, and the A1C change is pretty high, likely because it hits both GIP and GLP-1 at approximately 2%. There is no risk of hypoglycemia unless mixed with sulfonylureas. This also produces a pretty significant weight loss. Side effects include possible thyroid C-cell cancer risk, pancreatitis, nausea, vomiting, diarrhea. The special notes are that this was a newer drug approved in May of 2022. Dipeptidyl peptidase 4 or DPP-4 inhibitors go by the names of saxagliptin or Onglyza or sitagliptin, Januvia. The mechanism is that it inhibits GLP-1 degradation, which allows GLP-1 to signal insulin release when blood glucose is elevated, and also results in decreased glucagon in the fed state. Dosing for saxagliptin is 2.5 or 5 daily. Sitagliptin is 100 daily, and the administration is oral. A1C change is 0.5 to 0.8% on average. Hypoglycemia risk is not present unless mixed with sulfonylureas. The weight is neutral, so no gain, no loss. Side effects include pancreatitis, but otherwise these are pretty well tolerated. Special notes is that these are excreted renally, so monitor for the need to reduce in patients with kidney disease or kidney damage. Sodium glucose cotransporter inhibitors or SGLT2 inhibitors go by the names canagliflozin or Invokana, dapagliflozin or Farxiga, empagliflozin or Jardiance, or tugliflozin or Stiglatro. The mechanism is that these cause glucosuria by inhibiting the SGLT2 receptor and thus inhibits glucose from being reabsorbed in the proximal convoluted tubule of the kidney. The dosing for canagliflozin is 100 to 300 daily, dapagliflozin 10 daily, and pagliflozin 10 to 25 daily. The administration is oral. Average A1C change is 0.5 to 0.8%. There is no hypoglycemia risk. In terms of weight, there could be a loss. Side effects include UTI, yeast infections, and interestingly, euglycemic DKA can result from these SGLT2 inhibitors. So physicians and providers need to warn patients to stop taking the medication if they become ill or are under any form of physiologic stress such as surgery or an injury. Special notes include that these can be used to decrease blood pressure, slow kidney disease, and as GDMT or goal-directed medical therapy in heart failure. GFR less than 20 or 30 is where glycemic control wanes and this medication is not as useful for glycemic control. But for CKD, it is still useful even at a low GFR, as it helps slow kidney disease. It is still a useful therapy when beta cells have stopped working because the mechanism is not dependent on glucose and insulin interacting, which is great for this drug as we can use it as patients continue to progress in their diabetes. Sulfonylureas have two generations. The first generation's chlorpropamide, tolazamide, tolbutamide, and the second generation glipizide, which goes by glipizide XL, and glucotrol, glimepiride goes by Amaryl, and glyburide goes by micronase or glinase. The mechanism is that these inhibit the potassium ATP channels in beta cells, which results in calcium-induced exocytosis of insulin, and therefore insulin release. It also decreases liver gluconeogenesis, which decreases the amount of sugar that the liver is able to produce. The dosing for glipizide is 1.5 to 10 daily, glyburide 2.5 to 10 daily, up to 20 in some cases, and glimepiride is 2 to 4 daily, up to 8 in some cases. The administration is oral. Average A1C change is 1 to 2%. Hypoglycemia risk is high because these trigger insulin release regardless of the glucose level, so they are glucose independent. The weight, there's a possible risk of having weight gain, so consider not prescribing to patients that are already dealing with obesity. Side effects include hypoglycemia, nausea, diarrhea, dizziness, and headache. Special notes include that the second generation is preferred because first generation has a higher hypoglycemia risk because of a longer half-life. These are not typically your first-line agents. Glipizide is preferred in CKD, and this is also a cheaper option. So in some cases, this may be used when finances have become an issue for a patient. Meglitinides are also similar to sulfonylureas, so could also be grouped under that category, but the names are repaglinide, or Prandin, and nigteglinide, or Starlix. The mechanism is similar to sulfonylureas, as these drugs act on potassium ATP channels, resulting in insulin secretion. The dosing for repaglinide is A1C less than 8, you would do 0.5 before meals, A1C greater than 8, 1 to 2 before meals. Nigteglinide is 60 to 120 before meals. The administration is oral. Average A1C change is 0.1 to 2.1%. Hypoglycemia risk is less than sulfonylurea, but still present. There is a potential for weight gain. Side effects include URI, sinusitis, and possible cardiovascular risk. Special notes are that this is shorter acting, so it's given with meals, and repaglinide is useful in CKD because it's hepatically excreted. Thiazolidinones, or TZDs, go by the names pioglitazone, or Actos, and rosiglitazone, or Avandia. The mechanism of these is that these drugs agonize the PPAR receptor, which causes adipose muscle and liver to take in glucose and decreases insulin resistance. The dosing is for pioglitazone 15 to 30 daily and can increase up to 45 in some cases. Rosiglitazone is 4 milligrams daily and it can increase to 8 daily after no response in 8 to 12 weeks. The administration is oral. Average A1C change is 0.5 to 1.4%. Hypoglycemia risk is low. There is a chance of weight gain. Side effects include edema and possibly causes heart failure and can also cause an increased risk of fractures. Special notes include: do not start this in a person with CHF, hepatic impairment, or in patients prone to have fractures. This can be used in patients with renal disease.